ايوه كده، ايوه كده. ايه اللي بسامع؟
ابدا من الاول ولا منين؟
من هنا، من هنا.
It's okay. Whether IVF is thrombogenic? Yes. The answer is true. IVF is thrombogenic. Yes, Emma. IVF increases the absolute risk of venous thromboembolism. This risk ranges in the different studies between 0.8 and about 1%. And this risk is exactly similar to the woman using the combined oral contraceptive pills. The risk of venous thromboembolism occurs during the different stages of IVF, even in the absence of pregnancy or other predisposing factors. The risk during stimulation is exactly similar to that of pregnancy. Unfortunately, if the woman developed ovarian hyperstimulation syndrome, and I should stress any form or any degree of ovarian hyperstimulation syndrome will increase the risk of developing venous thromboembolism to about 100-fold more than normal. The second question, whether pregnancy following IVF in particular increases the risk of developing venous thromboembolism, and unfortunately the answer is yes. Yes, Anna. The answer is true. Yes. The risk is much higher if pregnancy occurs, and if we have compared, yes, Anna. If we have compared the natural pregnancy to that of pregnancy following IVF, we'll find that the risk of thromboembolism is much higher during a pregnancy after IVF when compared with the natural pregnancy. Yes, sir. And this risk during pregnancy is highest during the first trimester. Then it will start to decrease gradually till the end of pregnancy. This is conditioned, and the condition is that there should be no other predisposing factors. In the presence of other risk factors, the risk of venous thromboembolism will increase as pregnancy advances. And these informations and this data have been documented in many systematic reviews and meta-analyses. Not only that, not only the risk is high during pregnancy, but also, yes, Emma, the risk increases, the risk persists throughout the postpartum period. Yes. And a woman with who developed thromboembolism during pregnancy following IVF, it carries a risk of thromboembolism till about 10 weeks postpartum. Once again, the risk of developing thromboembolism during the postpartum period is much higher in pregnancy following IVF when compared to the natural pregnancy. The third question, whether there is any peculiar or specific risk factor during a pregnancy following IVF which increases the risk of thromboembolism or not? The answer is definitely sure, yes. First of all, I will discuss that the IVF itself is a risk factor, but the fresh cycles, no, sorry, again, backward, please. Backward. Yes, the risk of fresh cycles is much higher than the frozen cycles and developing thromboembolism. Yes. The number of pregnancies markedly affects the risk of thromboembolism, where multiple pregnancies are associated with a much higher risk of venous thromboembolism when compared to the singleton pregnancy. How does IVF increases the risk of thromboembolism? By many mechanisms. The first, and it is the strange gonadotropins themselves, induce a hemostatic changes, particularly a high estradiol level, and all of us know that the estradiol has a thrombogenic effect, which is exactly similar to pregnancy. No, backward, please. Backward. Yes. You should keep in mind that the urinary FSH is associated with a much higher risk, and this is particularly due to HCG content. Next, please. Yes. The HCG, you should always keep in mind that the HCG is the main trigger for the coagulation cascade, and it is uncommon for thrombosis to occur before the woman receives HCG. Yes, next. Despite all of these data and information, you should be cautious, and many things that you keep in mind is that the risk of thromboembolism during the stimulation is uncommon, and the predisposing factors are usually needed. And one of you may say that or ask me that you jumbled us or you have complicated the situation. No, I didn't complicate it. And this data indicate, yes, this data indicate that, yes, the multi-hit nature of venous thromboembolism. For thromboembolism to occur, one or more risk factors are usually necessary. So yes, the stimulation itself carries a risk, but this risk is very high in the presence of other risk or other predisposing factors. The next question, whether the clinical presentation of thromboembolism following IVF is exactly typical to the conventional thrombosis or not. The answer is no. Yes. And the venous thromboembolism following IVF is totally different from the conventional thromboembolism in that there is unusual and surprising predilection for upper extremities and neck affection when compared to the lower limbs and side in the conventional thromboembolism. And always you should keep in mind that if a woman after IVF develops something in the neck or pain in the upper limbs, you should not ignore and you should not ignore the complaint of the patient. But why? Why this is unusual presentation of thromboembolism? Yes. All of us know that the main drainage of the peritoneal cavity is through lymphatic through the thoracic duct, which will drain into the subclavian vein. Yes. And it has been postulated that drainage of the peritoneal fluid, particularly following ovarian hyperstimulation syndrome, which is very rich in inflammatory mediator, will go through the thoracic duct into the subclavian veins, and these inflammatory mediators will initiate the coagulation cascade there. And this is one of the theories which is explaining why there is a special or particular predilection of the neck and the upper limbs. Yes. Risk factors during pregnancy itself, yes, which increase the risk of venous thromboembolism. The first and the most important, ovarian hyperstimulation syndrome, and I will stress any degree of ovarian hyperstimulation syndrome. The second is the high estradiol level. The third is the HCG, which is a most important trigger for the process of coagulation cascade. The next is pregnancy, whether single or multiple, and lastly, the use of synthetic estradiol for frozen cycle preparation. Yes. Whether all of us know that prevention is better than cure, whether there is any way that will prevent the occurrence of this catastrophic event, yes. Definitely, the implementation of what's called ovarian OHS free cycles will decrease the risk dramatically. The second is single embryo transfer, because many studies show that the risk is much higher in multiple pregnancy when compared with the singleton pregnancy. Natural cycle frozen embryo transfer to avoid the use of the synthetic exogenous estrogen. If artificial cycle is chosen, or if the natural cycle is not possible, we should always use natural estradiol. And if this natural estradiol is not available, no, please, we should use a prophylactic anticoagulant. But always remember that this should not be in all cycles. That should be implemented only in the presence of other risk factors. This means frozen embryo transfer with other predisposing factors. So you should use a prophylactic anticoagulants. Yes. Whether there is any guidelines for the prevention of thromboembolism during pregnancy, yes, the only available guidelines is elaborated by the Swedish Society of Obstetrics and Gynecology in 2015. Yes, and these guidelines, the first step in preventing the venous thromboembolism is starts by a preconceptional risk assessment, adequate history taking, adequate investigations should be, and adequate family history in order to assess the risk of acquiring thromboembolism during pregnancy. This is very important. The second, there are certain risk factors that should be kept in mind which put the woman at the highest risk of developing venous thromboembolism. The first, yes, Sama. The first is the ovarian hyperstimulation syndrome. The second is recurrent or previous history of venous thromboembolism. The third is antiphospholipid syndrome with venous thromboembolism. And the most important and the most dangerous is antithrombin deficiency. Antithrombin deficiency will put the woman at the highest risk of developing venous thromboembolism during pregnancy or during the course of IVF itself. Yes. The guidelines state that routine prophylaxis or the routine use of enoxaparin is not indicated in a patient without risk factor. So if there is no risk factor, heparin is not indicated. However, if the woman developed ovarian hyperstimulation syndrome, she should pass through this algorithm. If she was not pregnant, the enoxaparin should continue for 4 weeks after resolution of the manifestation of ovarian hyperstimulation. And I stress again, not for 4 weeks, 4 weeks after resolution of the manifestation. On the other hand, if the patient was pregnant, the management will be totally different. This will depend upon the risk assessment. If there is no any other risk factor, this heparin, this anticoagulation should continue till the end of the first trimester. However, in the presence of other risk factor, the management will depend upon, and the continuation of enoxaparin will depend upon your risk assessment that has been conducted before starting the IVF. Unfortunately, about 10% of patients with severe ovarian hyperstimulation syndrome develop venous thromboembolism despite of full anticoagulation. So please, this patient requires an additional care, particularly in the ICU, with a very extensive investigation in order to detect any early stages of the coagulation abnormalities. All of us know that the timing is very important. Yes, when to start this anticoagulation. It's very important to start early in the presence of any other risk factors before the start of the synthesis of the clot. You should start the enoxaparin with the onset of your stimulation. You can omit it on the day of oocyte pickup, despite that's not so essential, then restart it again. Yes. What about the amount of enoxaparin the woman should receive? It's variable, but according to the risk assessment And this is, yes, one table which simplify according to the body weight the amount of heparin that's needed. In normal body weight about 40 milligram per day, but again, this is in the absence of other predisposing factor. The presence of any other predisposing factor will change this amount. If the woman is obese, she can receive at least 80 milligram per day of enoxaparin. Yes, sir. Lastly, I should close this presentation with a brainstorming in order to revise and take home message. We should take something to our home. Yes, Sama. If you have supposed confronted with a 27 years old lady, she had primary infertility 6 years, her cycles were totally irregular, she was obese, and with a previous history of cerebral sinus thrombosis. Yes, she was treated with heparin, and now she was on oral anticoagulant for 6 months. Her thrombophilia scan was normal. She was diagnosed as typical polycystic ovarian disease, and her husband was suffering of oligoteratospermia. She was allocated into an exit trial. Yes. So the first question, which protocol? Yes. This woman is PCO, definitely you will select the antagonist protocol. Yes. The type and the dosage of gonadotropin, yes, definitely. The recombinant FSH in this lady in particular is much safe than the urinary FSH. You want to get rid of the HCG, and mild stimulation protocol is advisable in order to decrease the possibility of ovarian hyperstimulation syndrome in women with PCO. Yes. Whether she will receive anticoagulation or not, this lady, yes, definitely. She is obese. She has polycystic ovarian disease with increased risk of ovarian hyperstimulation syndrome. Not only that, she has a previous history of cerebral venous sinus thrombosis. All these factors culminate in putting the woman at the highest risk for developing thromboembolism. So the dose will be at least 120 milligram per day of enoxaparin at least. Yes. On day 10, she had 11 follicles, and the E2 was about 3,000. Yes. Now she is ready for trigger. Yes, I think the answer, you will know it. You will trigger it by the GnRH analog, not by the HCG. Yes. She didn't develop manifestation of ovarian hyperstimulation syndrome, fortunately, and she yielded 4 good quality blastocysts. So your next plan in this lady in particular will be fresh or frozen cycle. Yes. Once again, this woman is very high risk for developing ovarian hyperstimulation syndrome. So we should implement the policy of freeze all, okay, with single embryo transfer in the next cycle. Yes. Frozen cycle preparation. Yes. How you'll prepare? As we mentioned before, natural cycle in this woman is possible or not? Yes, it's definitely not possible to prepare the woman using the natural cycle because her cycles were totally irregular. So hormonal or artificial cycle is necessary. So which type of estrogen you will use? Okay, by far the best is a transdermal estrogen, which is natural estrogen, which has less impact on the coagulation cascade. Yes. Okay, single blastocyst that was transferred in the next frozen cycle. Unfortunately, the patient was conceived. The patient conceived. So, what's your next plan in this woman in particular? Definitely, you should use enoxaparin throughout pregnancy. The woman has the 3 risk factors, not only throughout pregnancy, but at least 10 weeks postpartum. Yes. Take home message. Yes, please, you should avoid. And I'll wait for this slide to come down. Yes, sir. Yes. Please give this slide some time. You should avoid what's called heparin. I'm intentionally doing that in order not to forget it. You should avoid heparin paradox. Heparin paradox, it means that the heparin or enoxaparin is used when not necessary, and it is not used when it should be used. Yes, Sam. And I am always closing my presentation with this immortal statement: life is finite while knowledge is infinite. And thank you, dear chair and dear professor, that I have skipped my allocated time. Thank you.